Hallek, what is your standard treatment for fit patients with chronic lymphocytic leukemia?
The current standard treatment for patients with CLL that are physically fit is a combination of fludarabine, cyclophosphamide, and rituximab, FCR.
And is that the treatment that you typically give to your patients?
So when a patient comes with good physical fitness, we usually give FCR. In some cases where the fitness might be slightly reduced, we are sometimes also using bendamustine.
What are your criteria for determining the eligibility of patients for aggressive treatments such as FCR?
So if we have to decide or to choose treatments for patients with CLL, we usually look at the fitness. And I think a good physical exam and a good evaluation of the patient is a very good first step. In our trials, we have established a system that is composed of two elements: a cumulative illness rating scale, the CIRS score or CIRS scale, and we are looking at the comorbidity in different organ systems, and that's basically what is every physician doing on a daily basis to evaluate the concomitant diseases in a patient. And we also assess the creatinine clearance. And with these two simple parameters, we are actually making the decision. Our CIRS score greater than 6 is usually going to the less aggressive treatments, and the creatinine clearance below 70 ml per minute or 60 ml per minute is usually also an indication to reduce the treatment intensity.
And do you use age as a criterion at all for determining patient fitness?
When it comes to the treatment decision, age is not a discriminator at all, at least in my practice, and also not in the German studies.
What percentage of your patients are not eligible for aggressive treatments such as FCR?
So when it comes to the percentages not being eligible, that's a very good question. So in a university or academic center, the majority of our patients is very fit. I would even say 80% or 90% of our patients are fit enough to get aggressive or normal standard chemoimmunotherapies. Now, we know from statistics in geriatric oncology that at the age of 70, overall, there is approximately 60 to 70% of all patients that are fit enough to get any intensive chemoimmunotherapy, and only 30% are not fit enough, which is interesting. When it comes to 75 or 80, then these numbers are much lower. So if you have an 80-year-old patient, usually it's just the opposite. About 30 to 40% are fit enough to get any chemotherapy, and then the majority, meaning 60%, are what we call slow-go patients with reduced fitness. But I think it's one of the most important things to teach, that usually patients, even at the age of 70, are very fit, at least in the Western countries. It's a little different in, for instance, Russia. We are doing trials where we include patients in Russia, and actually their fitness at the age of 60 is sometimes lower at an average than in our countries like Canada, Germany, Sweden, European countries at the age of 70.
And what type of patients do you feel should not be given fludarabine?
What type of patients should not be given fludarabine? That's an interesting question, because I think fludarabine monotherapy could be given to many more patients, but you're probably referring to chemoimmunotherapies and combinations of therapies, because that's the current standard. And I think it's as simple as repeating again that any patient that is not fit enough should not get FCR combinations or FR combinations. There is also some contraindications. Patients that are severely immunosuppressed should eventually not be treated FCR first line, or at least there is a caution to do that. And finally, there is there are rare side events in patients that had prior experience to fludarabine. So any toxic effects of fludarabine, like there's rare skin toxicity or kidney toxicity, in these cases, patients should not be retreated with fludarabine.
What treatment do you offer patients in the slow-go category?
So the patients that are not so fit, and we call them slow-go patients, We usually offer them chlorambucil in Germany as a first-line therapy, and we are now conducting trials where we would actually use combinations of chlorambucil plus rituximab or chlorambucil plus a new antibody GA101, which is more efficient. And this is actually, in my opinion, going to be the new standard, any antibody plus chlorambucil. Now, there is sometimes in patients that are not so fit, the question that is frequently asked in my practice, whether we should intensify the chemotherapy component by using bendamustine. And this is not so clear. There's an unfortunate situation that we don't have clinical evidence or data for that in the unfit population. But I think the bendamustine treatment comes somehow in between. So FCR being a little bit more toxic, bendamustine currently being used also sometimes in the not so fit patients. And then for these low-go patients that are really fulfilling the criteria, we give chlorambucil with or without rituximab. So these are probably the options.
So in patients that were a little bit more fit, you might use bendamustine, and then if they're really more frail, you stick to chlorambucil?
Yeah, so again, this is a good approach. It is not based on evidence. Germans have a long tradition of using bendamustine because it was a former Eastern German drug that was transferred into Western Germany, funnily enough. So there's lots of experience. It's a lot of very small studies, so not a systematic evaluation. And I would say, yes, it is a possible approach, but we have to do trials with bendamustine in the elderly population.
What treatment do you offer patients who have mild to moderate renal or liver dysfunction?
So there is another element actually distinguishing the slow go patient, that's the renal function, as you rightly say. And again, this is where we either go for chlorambucil because it's less toxic than at least fludarabine, but also bendamustine usually doesn't have a lot of nephrotoxicity, and therefore it would be an option to use both drugs, either bendamustine or chlorambucil in combination with rituximab in patients with reduced kidney function.
In which patients do you then offer bendamustine? And when you do give bendamustine, do you tend to give it as a monotherapy or do you give it in combination?
The times of using bendamustine as a single agent are almost over. So I'm always giving it in combination with rituximab, even in the not so fit or slow go patients, because there is enough evidence to suggest that these combinations will fare better and the patients will benefit from that. Although, again, this is without formal evidence. I should say that this is more clinical practice that and my personal experience, but it's not based on strict evidence. The new CLL10 trial, the trial that will probably finish and present data next year, will clarify whether bendamustine rituximab is equivalent to FCR in the physically fit patients. But what we would need, though, is to test bendamustine in the physically not so fit patients in combination with rituximab. So I'm eagerly awaiting that somebody is doing these trials.
And where would you tend to give bendamustine with rituximab, in which patients?
Basically in all not so fit patients I would start, and then the major field of using bendamustine rituximab in my own practice is in second line treatment. So when patients actually come after FCR first line treatment and relapse, then very frequently we are using bendamustine rituximab as our first choice for second line treatment.
And are there any patients who you would deem as being too frail to get bendamustine rituximab?
Yes, there are clearly patients that are too frail to receive either FCR or bendamustine rituximab, and that's probably patients that have a very short life expectancy. We call them no-go. There's not a formal criterion that we have established, but I can give clinical examples for that. So as an example, a patient that has a very, very strong heart insufficiency, grade NIHA 4 or NIHA 4, which is usually defining a life expectancy of less than 1 year or around 1 year. In these patients, very frequently, the CLL is not the major problem. And in these instances, we simply decide to not treat CLL anymore, and we don't apply any treatment usually. And there's other conditions like severe dementia or Alzheimer's where you can say, well, is it really necessary to treat CLL, or wouldn't it be more, let's say, respecting the dignity of the patient if you wouldn't treat the leukemia at all anymore. So in these instances, we don't do any treatment. But this is a relatively vast field, and up to this point, we should treat patients correctly, and that means bendamustine could be used, chlorambucil could be used in combination with rituximab.
What dosing regimen of bendamustine do you tend to use, and what number of cycles and cycle duration do you usually advise?
Mm-hmm. So the dosing of bendamustine is one of the understudied fields in CLL. We know that in second-line treatment sometimes you encounter strong toxicity. We've done a formal phase 1 trial where we were surprised to see high toxicity and had to go down. So in second line we recommend 70 milligram per meter square based on this small phase 1 trial. In first line, we recommend 90 milligram per meter square in combination with rituximab. So there are two different dose levels depending on the choice or depending on the situation, meaning second line or first line.
And how many cycles do you tend to give bendamustine for?
So the number of cycles are usually 6, although in the elderly or not so fit slow-go patients, sometimes you encounter myelotoxicity and have to stop earlier. So it's not an infrequent event to stop the treatment after, let's say, 3 or 4 cycles due to myelotoxicity.
What are the advantages of bendamustine as a general treatment for CLL?
The advantages of bendamustine as a drug in general, and actually also for CLL, are you don't have any alopecia, so you don't have any hair loss. It's easy to give. You only have 2 days of infusion maximally, and a short infusion, so it reduces the time in the practice or the infusion time. And also all the other side effects like nausea and everything else are extremely reduced. So it's a very convenient drug, and that's why it's getting so popular. At least it has become popular due to that in Germany and probably also in other countries now.
Do you have any safety concerns with the use of bendamustine?
Bendamustine has its own side effect spectrum and properties, and so the concerns are that you have to watch out for long-term myelotoxicity. That is, as opposed to FC as a combination, or as opposed to many other chemotherapeutics, it can induce long-lasting myelosuppression. So you have a wave of, let's say, neutropenias, for instance, going down at 3 weeks and then coming up again, and then it may actually go down again after 5 weeks or 6 weeks. So sometimes in your patients you have to watch for prolonged neutropenias and prolonged myelosuppression. In these patients, it's sometimes difficult, if not dangerous, to continue the treatment. So I would say that this prolonged myelosuppression is one of the most important features in the management of CLL or other diseases. With this exception, it's a very well tolerated drug.
And what treatments do you offer to your CLL patients, and maybe describe what you would offer to a patient that's slightly more fit or slightly more frail as relapse treatment?
So the situation in a relapsed CLL patient is first of all, without any clearly defined standard. Very frequently, we simply ask whether the patient has responded well to the first-line treatment and then has had a long remission. In these cases, we simply repeat the first-line treatment. That's actually a golden rule. And long means 2 years. If it's longer than 2 years, we repeat. If it's shorter, then we do something else. Now, if a patient has a short remission, shorter than 2 years, after, let's say, FCR, we often switch to BR. So we change the treatment regimen, and actually also the other way around. If a patient has had BR at the first line instance in the physically fit situation, then we switch to FCR. Although in the physically fit, a shorter than 2-year remission is also a warning sign, and we usually ask ourselves and the patient, should we proceed to a transplant, because we know that they have a poor prognosis. In the SLOGO patients, it's different. There, bendamustine is very frequently a second-line option after chlorambucil, for instance, and we usually combine this with rituximab. And if that fails, then we move to alemtuzumab or something else. So we actually try to have a sequence of different treatments, and always the choice depends on the duration of the prior remission, with 2 years being a relatively good cutoff point.
Thank you very much.
You're welcome.